Here's a message from today's episode's sponsor.
Insulet, makers of Omnipod, are proud to partner with the Pharmacy Podcast Network to support the 2023 APHA Annual Meeting and Exhibition. The Omnipod 5 automated insulin delivery aid system is indicated for people with type 1 diabetes ages 2 years and older. Omnipod 5 is the first and only tubeless aid system in the United States that is exclusively available in the pharmacy. The Omnipod 5 combines a tubeless, waterproof, wearable pod that integrates with Dexcom G6 CGM to automatically adjust insulin based on glucose trends every 5 minutes. Visit the Omnipod team at booth 216 to learn more about this innovative technology. Disclaimers. The pod has an IP28 rating for up to 25 feet for 60 minutes. The Omnipod 5 controller is not waterproof. The Dexcom G6 is sold separately and requires a separate prescription. Visit omnipod.com/safety for additional important safety information.
You're listening to the Pharmacy Podcast Network.
In continuing a series that really, it means a lot to me. I take this personally. My background in understanding opioid use disorder treatment starts and taking patients from the emergency room and getting them involved in outpatient therapy. Being a director of strategy with New Season, you can find them at newseason.com. It was an eye-opener. And then when I came to pharmacy and bringing in this publication to pharmacists, when I found the article, which was through brown.edu, and it was titled "Pharmacists Can Start Patients on Road to Recovery from Opioid Use Disorder," the study shows. And everybody's heard of this. We also know that the Wall Street Journal and a couple other publications have picked up portions of this story, as if the public now gets to really get involved in understanding what pharmacists are doing with opioid use disorder and the pandemic that was happening, that was overshadowed, or the epidemic that was happening that was overshadowed by the pandemic and on COVID-19, which kind of shut it down because we were on a good trajectory of getting a little bit more public support around changes in policy and changes in how pharmacists are involved. That's what this series is about. And I am so excited that we're getting to continue some great guests. I want to introduce Dr. Jeffrey Bratberg, clinical professor at University of Rhode Island, which makes me think of my trip up the next time I come up to see UConn School of Pharmacy. Jeff, we are going to get together, but welcome to the show.
Thank you so much for having me. Great to be here.
I just got back from visiting the great school of pharmacy up at UConn. My godson is at UConn right now getting a marketing business degree. And he is a D1 player on your amazing football team. Go Wolverines up there. And it's good to know that there are people out there we can lean on to kind of bring us up to date on what the capabilities are of our pharmacist, our clinical pharmacist, our community pharmacist, as we were talking before, specialty pharmacist who understand specific disease states. Give us kind of your thought around this article or around where do pharmacists fit in the realm of opioid use disorder treatment?
Well, I appreciate that. And I'll do my best to summarize here. I think it really starts from the 30,000-foot view that community pharmacists, and really any pharmacist, are public health. And so if you're going to deal with public health, we have been lauded for our ability to take on COVID testing and COVID vaccination and pediatric vaccination and travel vaccination and travel clinics, all these kinds of things that pharmacists have been doing, and gave 50% or more of all the COVID vaccines. But prior to that, you mentioned sort of the pandemic within the epidemic, or however you want to say it, and that over 107,000 people have died, and from opioid related overdose. And what I've been championing for about 10 years now, almost exactly 10 years, has been expanded access to naloxone, which is a fantastic and life-saving drug. We're soon going to see it go over the counter, which may or may not increase its access. And so what I've done is work with a team of researchers working with me to say, okay, well, how, if pharmacists, what do they think about naloxone? How do we expand it? How do we implement it? But once people are saved from an overdose, which naloxone does, now we need to get them life-saving treatment so that they don't have another overdose. And as all my colleagues in recovery and treatment have said, you need that pharmacy, you need that medication first before you can rebuild your life, that path to recovery. And so we started applying for and getting grants to say, okay, well, what if instead of pharmacists just referring people to therapy, if they were dispensing naloxone or prescribing naloxone, what if we compared usual treatment to treatment in the pharmacy? Well, then the pandemic happened. So then we modified our study based on regulatory changes related to COVID and said, well, what if pharmacists start therapy? And that's where this revolutionary, but as you say, seemingly obvious thing to say, if pharmacists, we always say pharmacists that are most accessible. I like to think that pharmacists are the most visible, right? You don't drive down the street and go, oh, that's the doctor's office, I'm going to stop in and ask them for something. You don't do that. And if you're a person who's a marginalized person, a person who's in a vulnerable situation, and most likely a person who's been shut down by the medical community, unfortunately, for having a substance use disorder, opioid use disorder, maybe walking into a pharmacy where maybe you get your other medications, that should be the place that when you're ready, you can walk in and get started on life-saving therapy.
Jeff, imagine a pharmacist in your nearest health system. Let's give a call out to that hospital system. What's the nearest one?
The largest one in Rhode Island is the Lifespan Health System.
So the Lifespan Health System has these pharmacists. They're doing what they do. And there's a birthing center. And sure enough, the mother is going through either withdrawal or maybe under the influence. There's an article that came out on February 8th of 2023 from Stat News. And that's a great build out of really specific information, and one being healthcare trends, and the title says pregnant people with substance use disorders need treatment, not criminalization. And if you read through this article, you find out that there's missing classifications of what a patient needs based on so many different things. You could even bring up blood. You could take blood from somebody. You could find out more information, but the pharmacist could be inserted into that treatment of that mother that you're about to take into your nursery and maybe neonatal or whatever else is there that you're preparing this baby for. A pharmacist needs to be involved at that stage.
Yeah, I agree. And in fact, that builds on recent data that was just out showing that buprenorphine or buprenorphine naloxone, the combination, but we'll just call it buprenorphine products that our patients took in our study, is the best drug to prevent withdrawal and to safely treat pregnant people, and is lauded by those folks to, again, maintain a normal life. And so I think it's really important that we, again, just like naloxone, we really need everybody who's willing and able to start buprenorphine. Pharmacists should be involved. They should be involved in the stabilization, the maintenance, but also be part of a team of peer recovery specialists, social workers, physicians, nurses. I really, we did this as a team approach, and I think that we can expand the team so that not only are we making sure the person doesn't die because they're on life-saving medication for opioid use disorder, but they're also getting all the other services they need, with prenatal and perinatal care being one of those for people who can be pregnant.
Absolutely. And paying attention to that becoming part of the protocol, that they're pulling that pharmacist in immediately because that is. Do you know of a health system that has built something like that you've heard in the the hallways of pharmacy?
I know that there are, Boston is sort of a headquarters for innovations in addiction treatment and reaching out to people. I know that they have pharmacists on their addiction teams. And again, this is sort of honestly, unfortunately, a new concept that, people who have untreated addiction often get admitted to the hospital, and they more often than not don't get their addiction treated. And so then they leave and don't get their original problem treated. So on a even more urgent basis, community pharmacies are there to, again, if our model can be adapted to each state and each policy and policy changes that pharmacists can advocate for, we can get people started so that they don't go to the hospital. But if people go to the ED, the emergency department, they can get started there from pharmacists. There's a pharmacist colleague of mine, Natalia. She's presented at a conference on how they started people on methadone and buprenorphine in the ED and followed them there. But then there's also these addiction medicine services that are interprofessional teams that include pharmacists in hospitals to not only screen people who may go into withdrawal, like you explained in the hospital, and start them on medications right there, which we would do for anybody. If they were diagnosed with diabetes, would we say, sorry, go find your street insulin, is not something we do. But yet addiction is probably more deadly and often occurs too often.
Jeff, so during pregnancy, if a mother is on medication-assisted treatment, there is a specific substance that you've chosen for that specific. I can't remember.
Yeah, the drug's called buprenorphine. Yeah, but okay. Methadone is effective. Buprenorphine is effective, and again, these reduce morbidity and mortality dramatically in all people and are safe to use for pregnant people. So, the concept of coming together through SAMHSA, for example, that is the overseer of much of our education and policy within addiction medicine and treatment. That is the organization that the APHA can go to and form a partnership where we really funnel in pharmacists who are not only specialists in specific care, but also have that addiction understanding. And it doesn't stop at opioids. It could really, you could plug a pharmacist in any addiction category and really accelerate these addiction programs that I was personally involved with for 3 years, 82 medication-assisted treatment centers throughout the country. I saw pharmacists being utilized incorrectly, just as they would dispense the meds, and that was it. That's it. And then they would sit in there with their magazine, and I'm just like, what is going on? So when I started working with some pharmacists to really design some things, what do you know? We found comorbidity set in with many of these patients that were primarily there for just OUD. They don't care about anything else. Diabetics, mental disorders, hypertension, other things that were happening, that when the pharmacist got involved, we were able to do more for that patient holistically and drill down into medications that could have side effects or something like that together, where the pharmacist was inserted. Yeah, I think that, we just heard the State of the Union, and substance use disorders and mental health disorders were again brought up in terms of, massive and coordinated data-driven action needs to occur, and billions of dollars are being invested both from governments and from opioid settlement funds, and pharmacists need to be part of that. We don't have a behavioral workforce, is what I hear, but I look at pharmacists and what we teach them and what in accredited settings, both, in school and postgraduate settings, and saying, there's a whole psychiatric specialty pharmacy workforce, and there's the whole generalist workforce that could be utilized to treat, 50% of people with substance use disorders have mental health disorders. People with mental health disorders have substance use. We have to co-treat these in all settings. We need to do it in an interprofessional way. So we need it both in interprofessional, particularly behavioral health settings in teaching, and also we need to do it in practice. And of course, we need to all get paid for it in some sustainable way. A shout out
to the University of Pittsburgh School of Pharmacy, Dr. Joni Carroll, came to me through the Pennsylvania Pharmacists Association, and they're so interactive, which makes it really good for our state. I'm a Pittsburgh fan anyway, just a full disclosure. And so that unified also Duquesne University, and those three organizations came together and built an opioid use disorder treatment stigma series that was about the stigma of treatment, and bringing that to the minds of our pharmacists, who are these community pharmacy champions that might not have got that information in any other way. And we got it. Not only did we get a grant to sponsor that content, but we built 5 credits of continuing education, not 5, of 5 episodes. I think that's 2.5 credits if I do the math. But it was an honor that we got to be this facilitator to help pharmacists understand this, and then even get CE through it. And you've been a champion at doing that with grant funding from the NIDA, the CDC, and a bunch of other alphabet soups that are just so impressive. But share with me being involved and really being able to help educate the healthcare providers, the physicians, the nurse practitioners. That has to be fulfilling and exciting. Yeah,
I think one of my most proud things that I've done is been part of this organization called AMERSA, which is the AMERSA.org, and I'm on the board of directors and have been for many years. And we're growing. We're a small organization, but we're growing. But we have physicians, nurses, and I was one of the first pharmacists to be part of it. And now we've grown to a significant number of pharmacists doing this kind of work who want to or already work with other professions. It's the Association for Multidisciplinary Education and Research in Substance Use and Addiction. But that's why we say AMERSA. But we have a conference every year where there's pharmacists presenting along physicians, along nurses, with social workers, and people with lived experience. And it's one of the greatest things to see everybody there, that we have to stop being in opposition. And you talk about educating others through these webinars and things, which I've done as well on harm reduction and other things. I think the important thing is that physicians are not getting this knowledge, and so pharmacists are natural teachers. We are the ones educating patients and educating our colleagues of all professions. We need to have expanded access to prescribe addiction medications, because physicians have known about this for 30 years. They've gotten the education, and they aren't expanding the care. We hope with the data waiver being gone that we'd see expanded care, but we know that we could expand care to our other healthcare colleagues, like physician assistants and nurse practitioners. When they got the authority to prescribe buprenorphine, we saw greater expansion of care, especially in underserved areas and rural areas, which is where pharmacists are. And so that's why the education is the foundation for that, but we also need policy change so that we can act on that education as well. So, I'm a strange bird, Jeff. I'm kind of the public relations, strategist for the entire pharmacy industry. And we just got rid of the X waiver. Biden administration gets rid of it, right? And there were 8 hours of training, I guess, or something like that, which I think was ludicrous. I think there should have been more of a CE base. I don't think you should have had to maybe 8 hours to get the waiver, but you should have continued being educated by people that knew what's going on, and so many different avenues that we could go down, and continuing education needs, in just my opinion. But I see there being the time that pharmacists approach SAMHSA, for example, through maybe the APHA or whatever body that we pick. I think APHA is perfect. And we go to them and say, here, we got pharmacists that are specialists. There's a bunch of us that are out there. When I say us, I don't mean me, I mean you. I'm speaking on your behalf. And you start aligning other strategists that are out there, like, for example, Cardinal Health and Generation RX, and the fact that you were their 2016 NASPA National Cardinal Generation RX Award winner. Now, listen,
this is how things get done in business, let alone healthcare. I mean, healthcare is so complex, but we can build those inroads to each other and into these other bigger entities so that they realize, why in the world aren't we taking advantage of our pharmacists to lead this, input? And I'm not saying take anything over. We don't want it. Pharmacists do not. They're busy enough. They don't want to take anything over. Like, that's not it. It's let you do what you were designed to do and get out of your way and kind of let you build policy, technology platforms. Theragy that's out there? Theragy,
No.
Specialty pharmacy. It's a specialty pharmacy management program that is all about treatments and cases and big data and algorithm. I mean, it's a beautiful system that helps you to specialize in a very specific disease state. We could be building this, that pharmacists become, I don't know if you go to the board of specialties, Jeff, and say addiction medicine now becomes a specialty, because if we did do that, it really sets pharmacists up to being the ones that we go to, just as any specialist involved in specialty cancers or pregnancy issues or fertility or whatever it is. But tell me that isn't a model that you could see really making sense for public health.
Well, I think I see education as, I think addiction, both as an educational case and as a part of practice, is a part of everything. It's a part of the fabric of our society, both opioids, alcohol, nicotine, cannabis, whatever. Psychoactive substances are out there. They're always going to be out there, and everyone's going to use them. So our job, whether it's a medication that someone determined is legal or someone determined it's not legal, our job is to be aware of that, earn and keep the community and patients' trust, and make sure that people are using these substances in the least risky way as possible, while also connecting them to services. Every time I give a talk, I always start with this question to say, well, why are people using drugs? Right? Isn't that the right that we earned when, in the 50s, we couldn't even ask people why they were using their drugs. And we said, that doesn't make any sense as a profession. And we said, oh, maybe in every setting we work in, we find out why you're using it so we can say, stop using it, change it. These are the things I'm teaching my P1s to say, question things, right? That's our job. And we can, and again, as long as you have the patient's trust and we don't have that stigma to say, gosh, it's really hard to hear somebody say, well, I use heroin 3 times a day, or I use this, I really like fentanyl and I'm using it 6 times a day. And you go, well, okay, how can we help you with that? Should be our next answer. And if addiction medicine is part of that and the patient's ready, we need to be ready to deliver it to them, because too often people say, if you call an addiction specialist or a family medicine or whoever it is, a prescriber, they'll say, yeah, I have an opening in 3 weeks, and they'll be dead. And so this is literally life or death, both to reduce the stigma, to rapidly increase that education, to work together to say there are 8 or 9 out of every 10 people who want treatment are unable to get it. And our study shows that people want to do it in the pharmacy.
And it differentiates as well. Before I go into this next question I have for you, what does a lawyer do? Like, if you hire a lawyer or you have a lawyer on staff, that lawyer is there as an advisor to you, and in essence, to keep you from overspending on taxes or strategy or getting thrown in jail or getting penalized with something, right? You understand that every prescription that comes from the physician, AKA the client, and the pharmacist, AKA the lawyer, to keep your ass out of jail, like pharmacists, which sometimes will lock heads with a physician, the physician needs to understand, and this is just my call out because it makes it makes sense to me. Pharmacists are keeping you from killing people. They're keeping you from going to jail. They're keeping you from, they're protecting the patient first. And by protecting the patient, it's It's in many sometimes, and everybody makes mistakes, including pharmacists. But you're the last line of defense for the decision that was made by a physician, a very busy, stressed out, way too many patients probably per day, physician. That we're a team. We're not here to call you out and say we do things better than you do. We're just you're a specialist in something very specific. And we're talking about addiction medicine, and we're talking about a treatment, and we're talking about titration from methadone when someone wants to go to Vivitrol. And now you got a 5 to 9 day period where you got to get them clean before you get them on Vivitrol. What is that time period that I'm thinking of?
It would depend. That's my standard. It depends. But transitioning. I mean, those are complex things. Like I said, I'm just going to go back to say that pharmacists are public health. We are in a public health. We have accepted 100,000 deaths every year from addiction. It's only second only to COVID, and we seem to have invested a lot of money to try to defeat COVID in various ways. And we're not seeing those level of deaths. We only accept 430 deaths a day as of today of COVID deaths. But so many more people are dying of completely preventable deaths from opioid addiction. It isn't that people don't want therapy; they just can't access it. So what we're trying to study is, how do we increase that access? How do we, we can motivate and train physicians, but studies show that only 1/3 to 1/2 of doctors that had the waiver, so they went ahead and got all that 8 hours of training, they didn't have one patient that they were following. So getting rid of the waiver is a great thing. Removing all barriers, patient limits, those things are great. But a stressed out doctor who's got 200 patients can't take another one. So they need to work with pharmacists. Pharmacists need either autonomous prescribing ability or collaborations or both, in a sustainable payment fashion, to say, we're there to start people, to maintain them, to refer them to recovery and to other supports for what are likely a whole host of social determinants of health needs. And so that stressed out physician you described isn't vaccinating the person. Who is? We are. So if we can vaccinate somebody, we can also administer Sublocade, a long-acting buprenorphine product, or we can administer Vivitrol, a long-acting naltrexone product for either opioid or alcohol, better suited for alcohol use disorder. We need to offer every medication for opioid use disorder, including methadone. You go to Canada, guess where you get your methadone? You're getting it at a pharmacy. My colleague owns a pharmacy in Ontario. It's just normal. My Canadian colleagues go to this conference and they say, you can't get methadone in pharmacies. You've got to go to an entirely separate medical system. Yeah. What is that? So it's not even, hey, we're going to do this novel methadone thing. We're like, well, Australia, Scotland, Switzerland, Norway, Canada, all do it, and successfully. If we could add methadone, we can already do naltrexone, and maybe we can do buprenorphine in an induction fashion. Then we can start talking about the specialists to do the transitions and things. But we just don't nearly have enough people who are on life-saving treatment. So my goal is to start with that and educate people and destigmatize them.
And that's here we go with, we got 305,000 pharmacists in the country. It's just too many pharmacists. And I'm like, actually, give me 600,000 pharmacists and I will keep you all busy and I'll keep you all funded, because of being able to partner with payers and PBMs and multiple different facets of payment to show that if you just design these systems for us, we literally make healthcare more efficient because we're getting more out of the treatment. By the way, $4.325 billion Sacklers with Purdue were fined, right? Where's that money going? Give me some to build programs nationally from federal funding to create programs that partner with health systems, that partner with specialists, that partner with the MAT centers, because there's always these divides. Until I came to new season, nobody was using a pharmacist like that. Nobody was thinking, how could we really be? We're paying for them. Why aren't we? And that's what I came at it as a capitalist, to tell you the truth, Jeff. I was like, why in the world aren't we using our pharmacists to not only treat the way they should be, but we could make more money with these pharmacists because you could charge for an MTM or an incident to billing between the physician and the pharmacist. Like, that's whatever. I should be a strategist and go work for these companies, and maybe I'll make more money than podcasting.
Who knows? That's when you know you've made it, when there's more money in pharmacist addiction care than podcasting. There we go. I've laid down the gauntlet.
Oh, so I'm excited that we're talking about it and that there is a push for this. I think that organizations like the Pain Care event or the Pain event, or Dr. Garofoli always goes to that. And now I'm forgetting what that actually is called, but Pain Week. More pharmacists are showing up there and getting involved in that. Pharmacists that are talking about innovative care with digital therapeutics being involved, and how pair therapeutics has something that ties into addiction. This is such opportunities for us to, I feel like, what are you guys, the salt of healthcare, where it's like, now we're like getting the most out of everything, that if you just tapped in and understood that it makes more sense for the dollars being spent, that it's going to be that much more effective if we get you involved in treatment.
Absolutely. And again, as I work in our state to try to expand scope of practice to other public health interventions that other states have done, like access to hormonal contraception and smoking cessation and things like that. And we did our addiction research, and soon to publish our longer acting goals, which are right now looking good in a very preliminary way, but looking good in preliminary way is a good thing. We want, and looking for more grant funding to say, okay, well, so it seems like patients want to stay in pharmacies for 30 days. Do they want to stay for 3 months? Do they want to stay for 6 months? What does it look like when an opioid treatment program is the pharmacy that's also doing primary care, that's also doing public health, that's also dispensing PrEP and selling syringes and covering the whole spectrum of all medications, right? For some people, illicit drugs are not illicit drugs; they're medications. They're managing a condition, and managing that whole of these folks who are humans and deserve our care, but are not often thought of by the healthcare community as deserving of care, and thus they themselves don't think of themselves as care. And so I'm getting a little spiritual here, but it's the idea, like, when people take buprenorphine, their lives really do change. And our pharmacists saw that, and the patients saw that, and their partners saw it. And I can't become more of an evangelist that more medication access in our hospitals, in our clinics, in our communities, on mobile units, in pharmacy parking lots. I don't care where you do this. We got to start people on medication with as few barriers as possible.
Jeff, when I was in it, and proud of working for New Season and partnering with states that had grant money that didn't understand how it could be spent. And when we tore these politicians through one of our centers, and they got to see finally the connection, not only back to the center itself and the treatment, medication-assisted treatment, but how pharmacists could really take it to a whole nother level. And here's another point, especially when you're talking about grant dollars. It's the comorbid situations that the patient that all you're focusing on is the OUD has this whole other condition that if you just had a pharmacist just settle down for a second, this is a patient. This isn't an addict. Stop saying that. This is a patient. They need someone to review their hypertension medicine, or they need someone to jump on the HIV, or they need someone to understand the interaction between Suboxone and your pregnancy medication or your fertility medication, whatever that is. It's like a no duh. Like, if a pharmacist steps in, now that is a patient. That's not, we're not just focused on OUD. It's the whole patient, which is the whole dollar.
Well, I would argue the vice versa, that the person with hypertension who's not told anybody about their alcohol use disorder, if they get asked that question and you're a trusted member of their healthcare team, you could get them care that day, right? With appropriate policy change and reimbursement structures. And that has happened. If you're managing their HIV, people with HIV, larger proportion of those folks acquired HIV through syringe sharing because of lack of access to syringes and other harm reduction. That's a group that we basically eliminated in Rhode Island HIV transmission via syringes because we decriminalized them and we made them as accessible as possible. Those are ways that pharmacists can advocate for this. But that person with HIV, with an HIV specialist, also needs addiction treatment. That mental health specialist pharmacist also needs that addiction specialty knowledge, or at least general knowledge, so that they can, and the ability to start people on medications. I see great advantages to the VA system where pharmacists are integral and have there are policies for pharmacists to take care of folks across that spectrum of chronic disease states.
Health and Human Services in each of the states may or may not rely on pharmacists to really understand strategies around harm reduction and of course how to stop and start treatment for whatever reason, especially when we were mentioning transferring from one medication to the next. What kind of, through your research with harm reduction, for example, or overdose prevention and opioid safety, which is another one that you've touched on, kind of expand, how do we take pharmacists to start specializing in that? And that is study and diving down into the actual disease state and really starting to dissect that, which sets new standards in treatment.
Yeah, definitely. There's a lack of harm reduction. I mean, I always try to get people to think of like, this is not a foreign concept. When you counsel people on new medications or existing medications, it's always the efficacy and safety of it. We are risk reductionists, right? We don't want people to stop taking their meds because they had some known side effect that would go away if they kept taking it, for example. Or we don't want people to not report that they had trouble breathing on this medication and didn't seek care. So we're already risk communication experts, right? We're already experts in motivational interviewing. So it just makes sense, sort of what I mentioned earlier, that if people are taking medications that are not prescribed, that person, that patient, deserves risk reduction education there. And so once I frame that to different audiences, they all seem to get that, to say like, oh, of course, I want to drive my car as safely. I put a seatbelt on. I want to ride my bike as safely, so I put on a helmet. Harm reduction is all around us. Risk reduction is all around us. And so do we need more education in it? Yep. Do we need to do it with other professionals so we're sending the same message from across the healthcare spectrum? Absolutely. Is it easier said than done? Absolutely. But it really starts with understanding that people who use drugs are all of us, and that all of us deserve healthcare. And once you start that foundation, you go, oh, okay, you may not want to take this medication right now, but maybe we can figure out ways for you to use those substances in the safest way. So I think that's the thing, is that it's not a specialty. It is just what we do. It's part of everything we do.
I like that. It's already what pharmacists are trained to do, for goodness sakes. That's great. What's next for you? Are you going to be doing additional research specifically, or are you going to be working with other state or national associations in the great state of Rhode Island?
Well, what I've learned that I wish more people would learn, that when you publish something in the New England Journal of Medicine and you have PharmD after your name, a lot of people come calling when you're almost literally, because I tell people that my cell phone's on the web. It's on the URI website. Give me a text. It's fine. And nobody does. So I feel fine saying that. Maybe this is the wrong venue. I'll find that out. But no, it's been really, really encouraging that, to be sort of purposely vague, but there's lots of national organizations that are interested in advancing this. There are federal and state pharmacy folks and policy folks that are interested in this and instantly see the advantages to this. Again, when 107,000 people die every year, you can get policy people to say, how do we stop this? While medication's a way to do that, while more access is necessary. Okay. So I think I'm going to keep pursuing that policy change or policy analysis, replicating the study in a way that it's longer than the original 3 months in the comparator arms of the randomized control trial. I would also look to, again, my dream is that there's all 3 medications that we have right now, or all medications for substance use disorder, opioid use disorder, are available. So you could go find out that a pharmacy offers this care, no barrier access, and you can start buprenorphine, you can start methadone, or you could start naltrexone from that place, your choice, patient-directed care, and accessible to all 3 medications right now. So that's what I'm trying to figure out how to do.
You got your hands full, but I love it. Want to continue to support you. So proud of your work as a pharmacist, and really trying to get other pharmacists to understand that there are sometimes bigger paths and opportunities for you as a pharmacist than what you might think. And we're kind of going through this industry change of the role of the pharmacist, and it's expanding. So that's been amazing to see in our 14 years of podcasting, how much it has changed and how it's accelerating. And it's exciting to kind of be a part of pushing that messaging out. So you are welcome back on our network and on our shows. I'd like to get you and Dr. Mark Garofoli together for a pain pod. You got to join up the pain pod. I don't know if have you been a guest on there yet?
I have not been a guest on them yet. I have presented at pain conferences as well. Definitely a lot of overlap there with very, very talented pharmacists. I'm not one of those doing the care of people in chronic pain, and co-managing addiction is something that is of great interest to me as well.
I also wanted to say something. I want to dedicate this episode to Dr. Jeffrey Fuden, and just a shout out to how special he was to our network. He I think he was a guest 4 or 5 times, and every time he would bring like an entourage of listeners with him, because we would always preface it. But I want to shout him out and just say how much we miss him.
Absolutely. A very valued member of the profession in the world.
All right. Well, we are very thankful to you, Jeff, for sharing today and getting into this. Once again, we'd like to stage a time that you get to come back and kind of talk with us more about some of your additional findings, especially if you're going to be at a future conference, that we can get more eyes and ears around you. You're a champion, and we much appreciate you.
I appreciate it very much. I'd be happy to be back. Of course, I have my own podcast. I don't know if I'm allowed to co-mention it, but we did talk about the study in our most recent podcast called The Regimen that my students produce. So it's been a lot of fun. We celebrate our year of episodes, weekly episodes. And at the APHA conference, I'll be speaking with my colleagues on decriminalization of drugs. So that will be exciting.
We'll be there. We are the media partner for APHA 2023. We'll be running their podcast, Locked on Pharmacy, and it'll be so exciting to be there. So please send us a link of your podcast. We're going to share it on Twitter, Instagram, LinkedIn, and get it kind of tied into the future of pharmacy, literally, and kind of getting these young, aspired to be bigger things pharmacists, which will beat us all in the future because of nanotechnology.
And ChatGPT. So they can focus on advocacy. They can have ChatGPT write perfect testimony to allow them to prescribe addiction meds. I have no problem with that.
That is okay. You heard it first here on the Pharmacy Podcast Network, and Dr. Bratberg said it. So we'll coin it here.
Okay.
I appreciate you.
Appreciate it. It's been a pleasure. Thanks so much.